Hello everyone and welcome back to another deep dive into history's darkest chapters. I hope you're all settling in comfortably, whether you're bundled up in bed, relaxing on your couch, or just taking a moment to unwind from your day. And before we begin this fascinating journey back in time, let me know in the comments where you're tuning in from and what time it is for you, because I always love connecting with viewers from around the world and hearing about your different time zones and experiences. Tonight we're going to explore one of the most chilling aspects of 19th century life that most people today can barely imagine, and I want you to picture this scene for a moment. Imagine walking down a cobblestone street in London or New York City in the year 1850, the air thick with coal smoke and the smell of horses, when suddenly you hear the most terrifying sound a person of that era could encounter: the slow creaking wheels of a hospital cart approaching your home. Because in those days, when that cart stopped at your door, your neighbors didn't whisper prayers for your recovery, they whispered prayers for your soul, because everyone knew that entering a hospital in the 1800s wasn't a path to healing, it was quite literally a journey toward almost certain death. And the statistics were so horrifying that families would rather watch their loved ones die at home than subject them to the nightmare that awaited within hospital walls. The mortality rates in these institutions were so astronomical that they defied all logic and reason, with some hospitals reporting death rates of over 90% for certain procedures and surgical wards where infection was so rampant that the smell of gangrene and decay could be detected from blocks away. But what made these places so terrifyingly deadly wasn't just the lack of medical knowledge we take for granted today, it was an entire system built on practices that would make modern horror movies seem tame by comparison. And as we journey through this dark chapter of medical history tonight, you'll discover why the phrase "going to the hospital" was once synonymous with writing your last will and testament, why surgeons operated with the same tools they used to eat their lunch, why hospitals were intentionally built next to cemeteries not for convenience but because the death rate made it a practical necessity, and why the very people trusted with healing were often the primary agents of death, spreading disease from patient to patient with practices so unsanitary that modern medical professionals would consider them acts of deliberate murder. So settle in as we explore the horrifying reality of 1800s healthcare, where the cure was almost always worse than the disease, and where the white coats that symbolize healing today were stained red with the blood of countless victims of medical ignorance. And I promise you that by the end of this journey, you'll never take modern medicine for granted again. Because what you're about to hear will forever change how you think about the simple act of visiting a doctor or spending a night in a hospital bed. Let's begin our descent into this medical nightmare by understanding that hospitals in the early 1800s weren't the sterile, organized institutions of healing we know today. They were essentially warehouses for the dying, built not to cure but to contain, not to heal but to hide society's most unfortunate members from public view. And these institutions were primarily designed for the poorest of the poor, because anyone with even modest means would never consider setting foot in such a place, preferring instead to suffer and potentially die in the comfort and relative safety of their own homes. The very architecture of these early hospitals tells us everything we need to know about their true purpose, with long, dark corridors lined with beds crammed so close together that patients could literally reach out and touch their dying neighbors, creating perfect conditions for disease to spread like wildfire through the wards. And the buildings themselves were often converted workhouses, prisons, or monasteries. Structures never intended for medical care but repurposed out of necessity and a complete lack of understanding about what proper medical facilities should look like. Ventilation was practically non-existent, with tiny windows that were often sealed shut to prevent patients from escaping or committing suicide, because the despair and hopelessness within these walls was so overwhelming that death by jumping became a genuine concern for hospital administrators. And the air inside these institutions was thick with the smell of unwashed bodies, infected wounds, human waste, and death itself, creating an atmosphere so toxic that even the healthiest visitors would often become ill simply from breathing the air for extended periods. The lighting was dim at best, usually provided by a few candles or oil lamps that cast eerie shadows on the walls and made it nearly impossible for medical staff to properly examine patients or perform even the most basic procedures. And this darkness wasn't just inconvenient, it was deadly, because doctors and nurses often couldn't see the full extent of injuries, infections, or the spread of disease from one patient to another, leading to countless misdiagnoses and inappropriate treatments that killed more people than they saved. Water was scarce and usually contaminated, drawn from the same sources that received the hospital's waste, creating a closed loop of infection that guaranteed that any patient who didn't die from their original ailment would likely succumb to waterborne diseases like cholera, typhoid, or dysentery. And the irony wasn't lost on contemporary observers who noted that hospitals seemed to create more sickness than they cured, though they lacked the scientific understanding to comprehend why this was happening. The staff-to-patient ratio was abysmal, with one nurse often responsible for 50 or more patients, making proper care impossible and ensuring that most patients received attention only when they were already dying, and these nurses weren't trained medical professionals but rather poor women, often former patients themselves, who worked for minimal wages and had no understanding of disease prevention, wound care, or even basic hygiene practices. Food was scarce, spoiled, and often shared among patients regardless of their dietary needs or medical conditions, with the same gruel served to someone recovering from surgery as to someone suffering from stomach ailments, and meals were frequently contaminated with rat droppings, insects, and bacteria that thrived in the hospital's unsanitary conditions, meaning that patients who might have survived their original illness often died from food poisoning or malnutrition. The psychological torture of these institutions was almost as deadly as the physical conditions, with patients forced to listen to the constant moaning, screaming, and death rattles of their fellow sufferers, creating an atmosphere of such despair that many patients lost the will to live even before their medical conditions became terminal. And the sound of the dead being removed from the wards became such a regular occurrence that surviving patients developed a morbid acceptance of their own inevitable fate. Privacy was non-existent, with patients forced to endure the most intimate and degrading medical procedures in full view of dozens of other patients, stripping away the last vestiges of human dignity and adding psychological trauma to physical suffering. And this lack of privacy meant that infectious diseases spread not just through contaminated air and water but through the stress and weakened immune systems of patients who were psychologically broken by their experiences. The waiting lists to enter these hospitals were paradoxically long despite their reputation for death, because the poorest members of society had literally nowhere else to turn when illness struck, and families would often delay seeking hospital care until their loved ones were already at death's door, meaning that hospitals primarily received patients who were already too far gone to save, which only reinforced the institution's reputation as places where people went to die rather than recover. Religious services were conducted constantly throughout the day and night, not to provide comfort but because death was so common that last rites and funeral preparations became the primary activities of hospital staff, and the sound of funeral bells became so associated with hospitals that many communities began to protest their construction, fearing that the constant reminder of death would drive down property values and create an atmosphere of perpetual mourning in their neighborhoods. The admission process itself was traumatic and often deadly, with patients required to strip naked in front of strangers, surrender all personal belongings which they would likely never see again, and undergo examinations that were little more than cursory glances by overworked staff who had neither the time nor knowledge to properly diagnose conditions, meaning that patients with minor ailments were often placed in wards with those suffering from highly contagious diseases, virtually guaranteeing that they would contract something far worse than their original problem. Record keeping was practically non-existent, with most hospitals maintaining only the most basic logs of patient names and dates of death, meaning that families often never learned what happened to their loved ones, and many patients died without anyone even knowing their real names, buried in unmarked graves in hospital cemeteries that grew larger every year as the death toll mounted relentlessly. The financial aspects of hospital care were equally terrifying, with institutions charging fees that poor families couldn't afford while simultaneously providing care so inadequate that payment seemed like paying for one's own execution, and these fees often had to be paid in advance, meaning that families would bankrupt themselves to secure hospital admission for a loved one, only to watch helplessly as that person died anyway, leaving the survivors not only grieving but financially ruined and unable to afford proper burial or mourning rituals. Now let's delve deeper into the specific medical practices that made these hospitals so deadly, starting with surgery, which in the 1800s was performed without any understanding of sterilization, anesthesia, or even basic anatomy, making every operation a form of torture that patients rarely survived. And surgeons of this era were often former barbers or butchers who had no formal medical training but possessed steady hands and a willingness to cut into human flesh, qualities that were considered sufficient qualifications for performing life-or-death operations on desperate patients. The tools used in these surgical procedures were shared among multiple patients without any cleaning between uses, meaning that the same scalpel that had just been used to amputate a gangrenous leg would immediately be used to perform abdominal surgery on another patient, spreading infection and disease with surgical precision throughout the hospital population, and these instruments were often rusty, dull, and maintained with the same care that a carpenter might show his hammers and saws. Because the concept of sterile surgical equipment wouldn't be understood for decades to come. Anesthesia was completely unknown during most of the 1800s, meaning that patients undergoing surgery were fully conscious and aware during procedures that could last for hours, experiencing levels of pain that modern people cannot even imagine. And the screaming from surgical wards was so constant and horrifying that hospitals often had to be built far from residential areas to avoid disturbing the general population with the sounds of surgical torture. Surgeons operated in their street clothes, often wearing the same blood-stained coats from operation to operation as a badge of honor, believing that the more blood and gore on their clothing, the more experienced and skilled they appeared to patients and colleagues, never understanding that they were actually advertising their role as agents of death and infection, and these surgical garments were never washed, becoming breeding grounds for bacteria that would kill more patients than the surgeon's lack of skill. The operating theaters were public spectacles, with medical students, curious physicians, and even paying spectators crowding around the operating table to watch procedures, breathing on open wounds, contaminating surgical sites, and creating chaotic environments where sterile technique was impossible even if it had been understood, and these crowds often cheered or jeered the surgeon's performance as if watching a sporting event, adding to the psychological trauma experienced by conscious patients who were literally being cut apart for entertainment. Speed was considered the most important surgical skill, because without anesthesia, the goal was to complete operations before patients died from shock and pain, leading to rushed, sloppy procedures where surgeons prioritized quick cuts over careful technique, often leaving foreign objects inside patients, severing important blood vessels and nerves, and creating massive internal trauma that guaranteed post-operative complications and death. Post-surgical care was non-existent, with patients simply sewn up and left to recover or die on their own, often in the same beds where previous patients had died from similar operations, and surgical wounds were typically covered with dirty bandages that were reused from patient to patient, ensuring that even patients who survived the initial operation would succumb to massive infections within days or weeks of their procedures. The concept of washing hands between patients was not only unknown but actively discouraged by senior physicians who believed that soap and water would soften their hands and make them less capable of performing delicate operations, and doctors took pride in examining dozens of patients in succession without ever cleaning their hands, spreading disease with every touch and examination, unknowingly serving as the primary vectors for hospital-acquired infections that killed far more people than the original diseases that brought patients to seek treatment. Diagnostic techniques were primitive and often harmful, with physicians relying on practices like bloodletting, purging, and the application of leeches to treat virtually every condition, regardless of whether these treatments had any logical connection to the patient's symptoms, and these interventions often weakened already sick patients to the point where their immune systems could no longer fight off even minor infections, essentially torturing people to death in the name of medical treatment. The pharmacy practices of 1800s hospitals were equally deadly, with medications prepared in unsanitary conditions using ingredients that were often contaminated, expired, or completely unrelated to treating the patient's condition, and the same medicines were used to treat wildly different ailments, from broken bones to mental illness to infectious diseases. Because medical understanding was so limited that physicians believed most illnesses had similar underlying causes and, therefore, required similar treatments. Drug interactions were completely unknown, with patients often receiving multiple conflicting medications simultaneously, creating toxic combinations that poisoned their systems and caused organ failure, and dosages were calculated through guesswork rather than scientific measurement, meaning that patients regularly received either too little medicine to provide any benefit or too much medicine that would kill them through overdose or adverse reactions. The preparation and storage of medications took place in the same areas where surgical instruments were cleaned and food was prepared, cross-contaminating everything and ensuring that even patients who received appropriate medications would often be poisoned by bacterial contamination introduced during the preparation process, and many hospitals prepared large batches of medicines weeks or months in advance, storing them in conditions that promoted bacterial growth and chemical breakdown that rendered them not only ineffective but actively harmful. Mental health patients received treatment that was indistinguishable from torture, with physicians believing that insanity could be cured through physical abuse, starvation, and exposure to extreme temperatures, and these patients were often chained to their beds for months at a time, developing severe physical disabilities and infections that ultimately killed them even if their mental conditions might have been treatable through more humane approaches. The classification system for mental illness was so primitive that patients suffering from depression, epilepsy, dementia, and developmental disabilities were all grouped together and subjected to the same brutal treatments. and many people who were admitted to hospitals for minor mental health issues emerged as severely traumatized individuals whose psychological conditions had been made infinitely worse by their hospital experiences, assuming they survived at all. Restraint methods included metal shackles that cut into patients' flesh, straitjackets that restricted breathing and circulation, and isolation cells that were little more than windowless dungeons where patients were left alone for weeks or months with minimal food and water, and these restraints were often left in place until they became permanently embedded in patients' flesh, requiring surgical removal that usually resulted in fatal infections. The feeding of mental health patients was sporadic and often used as a form of punishment, with staff withholding food from patients who didn't comply with arbitrary rules or who exhibited behaviors that annoyed the attendants, and malnutrition became so common among mental health patients that it was considered a normal part of their condition rather than a result of deliberate neglect and abuse. Visiting policies were designed to isolate patients from their families and support systems, with most hospitals restricting or completely forbidding family visits, ostensibly to prevent the spread of disease but actually to hide the horrific conditions and treatment methods from public scrutiny, and families who were allowed to visit often found their loved ones so changed by their hospital experiences that they were barely recognizable, having lost significant weight, developed new physical disabilities, and exhibited signs of severe psychological trauma that hadn't existed before their admission. The training of medical staff was virtually non-existent, with most nurses and attendants learning their duties through trial and error, often at the expense of patient safety and comfort, and senior staff members passed down incorrect information and harmful practices to new employees, perpetuating cycles of medical ignorance and patient abuse that continued for generations without anyone questioning whether better methods might exist. Medical education for physicians was equally inadequate, with most doctors receiving only theoretical training that bore no resemblance to actual patient care, and many physicians graduated from medical school without ever having examined a living patient, performed surgery, or witnessed the effects of the diseases they claimed to be qualified to treat, making them essentially dangerous amateurs who experimented on desperate patients while learning their profession through fatal trial and error. The hierarchical structure of hospitals prevented lower-level staff from questioning the decisions of senior physicians, even when those decisions were obviously harmful or illogical, and nurses who attempted to advocate for patients or suggest alternative treatments were often fired or transferred, ensuring that harmful practices continued unchallenged and that patients had no advocates within the system that was supposedly designed to help them. Record-keeping practices were so poor that hospitals often lost track of patients entirely, with some individuals disappearing into the system and never being seen again by their families, and hospital administrators showed little interest in investigating these disappearances or improving tracking systems, suggesting that patient welfare was far less important than maintaining the illusion of competent medical care. The financial incentives within hospital systems actually encouraged high mortality rates, because dead patients required fewer resources than recovering patients, and hospitals could maximize their profits by admitting as many patients as possible while providing minimal care, essentially running death mills that generated revenue through volume rather than successful treatment outcomes. Staff members were often recruited from the criminal population, with hospitals offering employment to individuals who couldn't find work elsewhere, and these employees brought attitudes and behaviors more suited to prison environments than medical facilities, treating patients as prisoners rather than human beings deserving of care and compassion. And the violence and abuse that resulted from these hiring practices created additional trauma for patients who were already suffering from serious medical conditions. The religious aspects of hospital care were used more as tools of control than sources of comfort, with chaplains and religious staff emphasizing sin, punishment, and damnation rather than healing and hope, and patients were often told that their illnesses were divine punishment for moral failings, adding guilt and spiritual despair to their physical suffering and making recovery even less likely as patients lost the will to fight for their lives. The isolation of hospitals from mainstream society meant that the general public remained largely unaware of the horrific conditions within these institutions, and hospital administrators actively worked to maintain this ignorance by restricting access to journalists, prohibiting photography, and intimidating former patients and families into silence about their experiences, creating a conspiracy of secrecy that allowed abusive practices to continue unchecked for decades. Let's now examine the specific diseases that terrorized hospital patients and understand why these conditions spread so rapidly through hospital populations, starting with cholera, which was perhaps the most feared disease of the 1800s because it could kill healthy adults within hours of symptom onset. And hospitals became epicenters for cholera outbreaks because the disease spread through contaminated water supplies that were shared throughout hospital facilities, meaning that a single case could quickly infect hundreds of patients, staff members, and visitors in a matter of days. The symptoms of cholera were as horrifying as they were deadly, with patients experiencing violent diarrhea that could result in the loss of several gallons of bodily fluids per day, leading to severe dehydration, muscle cramps so painful that patients would scream in agony, and a characteristic blue discoloration of the skin that made victims appear to be turning into corpses while still alive. And hospital staff had no understanding of how to replace lost fluids or treat the underlying infection, so they simply watched helplessly as patient after patient died in excruciating pain. The speed with which cholera could sweep through a hospital ward was legendary, with morning rounds revealing dozens of new cases among patients who had appeared healthy the evening before, and the disease's rapid progression meant that hospital morgues quickly became overwhelmed with bodies, leading to the grotesque sight of corpses stacked in hallways, storage rooms, and even in the same wards where living patients were trying to recover from other conditions. Typhoid fever was another hospital killer that thrived in the unsanitary conditions of 1800s medical facilities, spreading through contaminated food and water supplies that were standard in hospital kitchens, and this disease was particularly insidious because its symptoms developed slowly over several weeks, allowing infected patients to spread the disease throughout the hospital population before anyone realized they were ill. And the characteristic high fever, severe headaches, and rose-colored rash that marked advanced cases created a horrifying spectacle in hospital wards where dozens of patients might be suffering from different stages of the disease simultaneously. The treatment for typhoid fever consisted primarily of bloodletting and purging, interventions that weakened patients' immune systems and made them more susceptible to secondary infections, and the mortality rate for hospitalized typhoid patients approached 90%, not because the disease itself was necessarily fatal, but because hospital treatments were so harmful that they killed patients who might have recovered with proper care or even simple rest and nutrition. Tuberculosis, known then as consumption, was perhaps the most persistent killer in hospital environments, spreading through the air in crowded wards where patients with advanced cases would cough blood and infectious material throughout the day and night, creating aerosol clouds of bacteria that other patients would inhale with every breath. And the characteristic wasting away associated with tuberculosis meant that hospital wards were filled with skeletal figures who appeared to be dying by degrees, coughing up increasing amounts of blood as their lungs were slowly destroyed by the infection. The recommended treatment for tuberculosis involved exposure to fresh air and sunlight, but hospital patients were typically confined to dark, poorly ventilated wards where the disease could only worsen, and the sight of tuberculosis patients in their final stages was so disturbing that many hospitals attempted to segregate these individuals, though cross-contamination was inevitable given the primitive understanding of disease transmission and the overcrowded conditions that made isolation impossible. Smallpox created some of the most horrifying scenes in 1800s hospitals, with patients covered in pustules that would rupture and leak infectious material throughout the wards, and the smell of rotting flesh from smallpox lesions combined with the visual horror of patients whose faces were completely disfigured by the disease created an atmosphere of revulsion and terror that affected both other patients and hospital staff. And many healthcare workers simply abandoned smallpox wards, leaving patients to suffer and die without any care whatsoever. The lack of understanding about smallpox transmission meant that hospital staff would move freely between smallpox wards and other areas of the hospital, carrying the infection on their clothing, hands, and medical instruments, and outbreaks would spread throughout entire hospital systems, killing not only patients who were admitted for smallpox treatment but also individuals who had entered the hospital for completely unrelated conditions and found themselves exposed to this deadly disease. Diphtheria was particularly terrifying in hospital settings because it primarily affected children, and pediatric wards became scenes of unimaginable horror as young patients slowly suffocated as the disease created thick membranes that blocked their airways, and the characteristic barking cough and struggled breathing of diphtheria patients created a constant symphony of suffering that traumatized everyone within earshot. And hospital staff had no effective treatments for the condition, leaving them to watch helplessly as child after child died in prolonged agony. The emotional toll on families was devastating, as parents would bring their sick children to hospitals hoping for miracle cures, only to watch them die under conditions that seemed designed to maximize suffering rather than provide comfort, and many families emerged from these experiences with psychological trauma that lasted for generations, creating deep-seated fears of medical institutions that would persist long after improvements in hospital care made such fears less justified. Pneumonia was another major killer that thrived in hospital environments, particularly during winter months when heating systems were inadequate and patients were exposed to cold, damp conditions that weakened their respiratory systems and made them more susceptible to lung infections, and the treatment for pneumonia typically involved bleeding and blistering, Interventions that further weakened patients' ability to fight off the infection and virtually guaranteed that the disease would progress to fatal complications. The progression of pneumonia in hospital patients was predictable and horrifying, with victims developing high fevers that caused delirium and hallucinations, followed by difficulty breathing that gradually worsened until patients were literally drowning in their own lung secretions. And the sound of patients struggling for breath created an atmosphere of constant crisis in hospital wards where staff members knew that most pneumonia cases would end in death within a matter of days. Sepsis, though not recognized as a distinct condition at the time, was perhaps the most common cause of death in 1800s hospitals, resulting from the introduction of bacteria into patients' bloodstreams through contaminated surgical instruments, unwashed hands, and infected wounds that were treated with dirty bandages and unsanitary techniques. And once sepsis developed, patients would experience rapidly rising fevers, confusion, and organ failure that inevitably led to death within hours or days. The signs of developing sepsis were well known to experienced hospital staff, who would recognize the characteristic smell of infection, the mottled skin coloration, and the rapid deterioration that marked the condition's progression, but their response was typically to increase bloodletting and purging. Interventions that accelerated the patient's decline and ensured that sepsis remained a virtual death sentence for anyone who developed it while under hospital care. Gangrene was a constant threat in hospital surgical wards, where contaminated instruments and unsanitary conditions virtually guaranteed that surgical wounds would become infected with bacteria that would cause tissue death and spreading necrosis, and the sight and smell of gangrenous limbs created some of the most horrifying scenes in hospital history, with patients literally watching their own body parts rot away while still attached to their bodies. And the standard treatment involved amputation with the same unsanitary techniques that had caused the gangrene in the first place, creating a cycle of infection and mutilation that often continued until patients died from shock, blood loss, or systemic infection. The psychological impact of gangrene on patients was devastating, as they would remain conscious and aware while watching their bodies decompose, and many patients begged for death rather than endure the prolonged agony of tissue death and the repeated amputations that were performed in futile attempts to stop the spread of infection. And hospital staff, lacking effective treatments, often simply avoided gangrene patients, leaving them to suffer alone in sections of wards that became known as death rows, where the most hopeless cases were left to die without interference. Dysentery thrived in hospital environments where sanitation was non-existent and water supplies were contaminated with human waste, and this disease caused such severe abdominal pain and bloody diarrhea that patients would become completely dehydrated within days. And the sight of dysentery wards, where dozens of patients would be simultaneously experiencing violent intestinal distress, created scenes of human misery that even hardened hospital staff found difficult to endure. And the smell of blood and waste permeated entire hospital buildings, making it clear to visitors and patients alike that they had entered a place where human dignity and comfort were abandoned in favor of simply containing disease and death. The treatment for dysentery typically involved opium to reduce pain and various purgatives to cleanse the digestive system, but these interventions often made the condition worse by further dehydrating patients and interfering with their body's natural attempts to fight off the infection, and mortality rates for hospitalized dysentery patients exceeded 80%, making a diagnosis of dysentery essentially equivalent to a death sentence for anyone unfortunate enough to develop the condition while under hospital care. Malaria was endemic in many hospital locations, particularly those built near swamps or stagnant water sources, and the cyclical fevers and chills associated with malaria created another layer of suffering for patients who were already dealing with other medical conditions, and hospital staff had no understanding of the connection between mosquitoes and malaria transmission, so they made no efforts to control insect populations or eliminate breeding sites, allowing malaria to spread unchecked through patient populations and creating chronic health problems that persisted long after patients' original conditions might have been resolved. The combination of multiple diseases in single patients was common in hospital environments, where individuals weakened by one condition would quickly contract additional infections, creating complex medical situations that were far beyond the limited capabilities of 1800s healthcare, and patients might simultaneously suffer from tuberculosis, pneumonia, and dysentery, experiencing the combined symptoms of multiple deadly diseases while receiving treatments that were not only ineffective but actively harmful to their chances of survival. The seasonal patterns of disease outbreaks in hospitals created predictable cycles of mass death that hospital administrators learned to anticipate and plan for, with winter months bringing pneumonia and influenza outbreaks that could kill dozens of patients within weeks, while summer months brought cholera and dysentery epidemics that were equally devastating. And these patterns meant that hospital death rates would spike dramatically during certain times of year, overwhelming morgue facilities and creating public health crises that extended far beyond hospital walls. The lack of effective treatments for any of these diseases meant that hospital admission was essentially a death sentence with extra steps, and patients who might have survived their original conditions if left alone were virtually guaranteed to die from hospital-acquired infections. And this created a self-perpetuating cycle where hospitals maintained their reputation as places of death because they continued to kill the majority of patients who sought treatment within their walls, and families learned to view hospital admission as a form of prolonged execution rather than an opportunity for healing and recovery. Now let's explore the specific individuals who worked in these death traps and understand how their practices and attitudes contributed to the horrifying mortality rates that made hospitals synonymous with death, beginning with the physicians who were considered the most educated and skilled members of hospital staff but whose training and practices were so fundamentally flawed that they often caused more harm than help to the patients under their care. The typical physician of the 1800s had received his medical education through a combination of theoretical lectures and apprenticeships that bore little resemblance to modern medical training, and most doctors graduated from medical school without ever having performed surgery, delivered a baby, or treated serious infectious diseases, making them essentially dangerous amateurs who learned their profession by experimenting on desperate patients who had no other options for medical care. These physicians were typically upper-class gentlemen who viewed medicine as an intellectual pursuit rather than a hands-on healing profession, and they often spent more time debating abstract medical theories than actually examining patients, and their approach to diagnosis relied heavily on patients' descriptions of symptoms rather than physical examination. Because touching patients was considered beneath the dignity of educated physicians, and this distance between doctor and patient meant that serious conditions often went undiagnosed until they had progressed to fatal stages. The medical theories that guided physician decision-making were based on ancient Greek and Roman texts that had been unchanged for centuries, despite mounting evidence that these approaches were ineffective and often harmful, and physicians clung to practices like bloodletting and purging because these interventions were supported by respected authorities rather than because they produced positive outcomes for patients. And the medical establishment actively discouraged innovation and experimentation, viewing new ideas as threats to established authority rather than opportunities to improve patient care. The social status of physicians made them virtually immune to criticism or accountability, and patients and families who questioned medical decisions were dismissed as ignorant laypeople who couldn't understand the complexities of scientific medicine. And this arrogance meant that physicians rarely learned from their mistakes or adapted their practices based on patient outcomes, instead attributing treatment failures to the severity of patients' conditions or their failure to follow medical advice, and this attitude ensured that harmful practices persisted for decades without modification or improvement. Hospital physicians typically maintained private practices in addition to their hospital duties, and they often viewed hospital work as charity that enhanced their reputations rather than as their primary professional responsibility, and this meant that hospital patients received only a fraction of the attention and care that paying private patients enjoyed, and physicians would often rush through hospital rounds, spending only minutes with each patient and making treatment decisions based on cursory examinations that missed important symptoms and underlying conditions. The prescribing practices of hospital physicians were guided more by tradition and authority than by evidence or patient response, and the same treatments would be applied to vastly different conditions because physicians believed that most diseases had similar underlying causes, and patients would receive identical drug regimens regardless of their age, weight, other medical conditions, or individual responses to previous treatments. And this one-size-fits-all approach to medicine meant that many patients were either undertreated or poisoned by inappropriate medications that caused additional health problems beyond their original conditions. The surgical practices of hospital physicians were particularly horrifying because surgery was performed without anesthesia, antiseptic techniques, or even basic understanding of human anatomy, and surgeons operated primarily based on speed rather than precision, because patients frequently died from shock and pain during prolonged procedures, and this emphasis on speed meant that surgical errors were common, with surgeons often cutting important blood vessels, nerves, and organs while attempting to complete operations before patients lost consciousness or died on the operating table. The training of new physicians through hospital apprenticeships perpetuated harmful practices across generations, because senior physicians passed down incorrect techniques and dangerous procedures to medical students who accepted this instruction without question, and these students would then become senior physicians themselves, teaching the same harmful methods to the next generation of doctors. creating cycles of medical ignorance and patient abuse that persisted for decades without anyone recognizing the need for change or improvement. The nurses who worked in 1800s hospitals were typically untrained women from the poorest social classes who took these positions because no other employment was available to them, and they had no medical education, no understanding of disease transmission, and no training in patient care, making them little more than janitors and food servers who happened to work in medical facilities. And their lack of knowledge meant that they often unknowingly spread disease, administered incorrect medications, and provided care that was more harmful than helpful to the patients they were supposed to serve. These nurses were often former patients themselves who had survived their hospital stays and remained in the institutions because they had nowhere else to go, and their own traumatic medical experiences had left them damaged and often mentally unstable, and they would take out their frustrations and anger on current patients, creating cycles of abuse and neglect that added psychological trauma to the physical suffering that patients were already enduring, and hospital administrators did nothing to address this abuse because they viewed nurses as easily replaceable workers rather than important members of the medical team. The working conditions for hospital nurses were so poor that staff turnover was extremely high, with most nurses lasting only weeks or months before quitting or being fired. And this constant turnover meant that there was never any institutional knowledge or continuity of care, and patients would be cared for by a series of different nurses who knew nothing about their medical conditions, treatment plans, or individual needs. And this lack of continuity meant that important symptoms were often missed, medications were frequently forgotten or administered incorrectly, and patients' conditions would deteriorate without anyone noticing or intervening. The supervision of nursing staff was minimal or non-existent, with head nurses often being chosen based on seniority rather than competence, and these supervisors typically had no more training or knowledge than the staff they were supposed to manage, and this lack of qualified leadership meant that harmful practices went uncorrected, dangerous mistakes were repeated regularly, and there was no systematic approach to improving patient care or reducing mortality rates. The attitudes of hospital staff toward patients were often characterized by contempt and cruelty rather than compassion and professionalism, because the staff members came from social backgrounds that were only marginally better than those of the patients they served, and they often viewed their positions as opportunities to exercise power over individuals who were even more unfortunate than themselves. And this dynamic created environments where patients were treated more like prisoners than sick individuals deserving of care and respect. The pay for hospital staff was so low that many employees supplemented their incomes through theft from patients, stealing personal belongings, medications, and food, and this theft was so common that patients and families learned to expect it, and hospital administrators rarely investigated or punished these crimes because they viewed patient possessions as fair compensation for the low wages they paid their staff. And this accepted theft created additional trauma for patients who lost treasured personal items during the most vulnerable periods of their lives. The religious staff attached to hospitals often caused more psychological harm than comfort, because they focused primarily on preparing patients for death rather than encouraging recovery, and chaplains would regularly inform patients that their illnesses were punishment for sin and that they should accept death as God's will, and these messages of despair and condemnation destroyed patients' hope and will to live, making recovery even less likely and adding spiritual suffering to the physical pain that patients were already experiencing. The administrative staff of hospitals were typically more concerned with maintaining institutional reputation and financial stability than with patient welfare, and they would actively suppress information about mortality rates, treatment failures, and staff misconduct, and families who complained about patient care were often threatened with legal action or denied access to their loved ones. And this culture of secrecy and intimidation meant that abusive practices continued unchecked for years, or even decades, and hospital boards were typically composed of wealthy philanthropists who had never set foot in patient wards and made decisions based on financial considerations rather than medical outcomes or patient satisfaction. The maintenance staff who cleaned hospital facilities were among the lowest paid and least trained employees, and they used the same cleaning materials and equipment throughout the hospital without understanding how their practices spread contamination from one area to another, and mops used to clean surgical areas would then be used in patient dining areas. And the same buckets that collected waste from latrines would be used to carry drinking water to patient wards, creating cross-contamination that guaranteed the spread of infectious diseases throughout hospital populations. The kitchen staff who prepared food for patients had no training in nutrition, food safety, or dietary requirements for different medical conditions, and meals were prepared in unsanitary conditions using spoiled ingredients and contaminated water, and the same food would be served to patients with vastly different medical needs, from those recovering from surgery to those suffering from digestive ailments. and food poisoning was so common that it was considered a normal part of the hospital experience rather than a preventable complication of poor food handling practices. The security staff employed by hospitals were often recruited from criminal backgrounds and viewed their jobs as opportunities to exercise power over vulnerable individuals, and they used physical violence to control patients who complained about their treatment or attempted to leave the hospital against medical advice, and these security personnel often abused patients sexually, physically, and psychologically, knowing that their victims were too sick, too poor, or too powerless to seek justice or even report the crimes that were being committed against them. The laundry workers who handled hospital linens had no understanding of disease transmission and would wash clothing and bedding from different patients together, including items contaminated with blood, pus, and other infectious materials, and these contaminated linens would then be distributed throughout the hospital, spreading disease from patient to patient and creating ongoing cycles of infection that could persist for months or years. And the soap and water used for laundry were often contaminated themselves, meaning that supposedly clean linens were actually more dangerous than unwashed items. The morgue attendants who handled deceased patients were typically the lowest status employees in the hospital hierarchy, and they often had drinking problems or mental health issues that made them unsuitable for other work, and their handling of corpses was careless and disrespectful, and bodies were often misidentified, lost, or disposed of improperly, and families would sometimes never learn what happened to their deceased loved ones. And the morgue areas became sources of contamination that spread disease throughout hospital buildings because proper isolation procedures were unknown and unenforceable. The hospital chaplains and religious staff, while ostensibly present to provide spiritual comfort, often caused additional psychological trauma by focusing obsessively on sin, punishment, and preparation for death rather than healing and hope, and they would tell patients that their illnesses were divine retribution for moral failings. And these messages of condemnation and despair destroyed patients' will to fight for recovery and added layers of guilt and spiritual anguish to their physical suffering. And many patients who might have survived their medical conditions died from despair and hopelessness induced by religious staff who viewed illness as evidence of spiritual corruption. The medical students who trained in these hospitals learned their profession through observation and practice on patients who couldn't consent to being used as teaching subjects, and these students would perform procedures they had never attempted before on desperately ill individuals, causing additional injuries and complications while gaining experience at patients' expense. And the competitive atmosphere among medical students encouraged them to view patients as opportunities to demonstrate their skills rather than as human beings deserving of careful, compassionate care. And this training environment produced physicians who were technically competent but emotionally disconnected from the suffering they caused. The visiting physicians who occasionally consulted on difficult cases were typically more interested in advancing their own reputations than in helping patients, and they would recommend experimental treatments or procedures that had never been tested, using hospital patients as unwilling subjects in medical experiments that were more likely to cause harm than provide benefit. And these visiting experts often contradicted the treatment plans of regular hospital physicians, creating confusion and conflict that resulted in patients receiving multiple incompatible treatments that interfered with each other and reduced the chances of recovery. The hospital pharmacists who prepared and dispensed medications had minimal training in chemistry or drug interactions, and they often substituted cheaper ingredients for prescribed medications without informing physicians or patients, and they would prepare large batches of medicines in advance, storing them in conditions that promoted contamination and chemical breakdown. And patients would receive medications that were not only ineffective but actively poisonous, and the pharmacy areas were often located next to latrines or garbage storage areas, ensuring that all medications were contaminated with bacteria and other harmful substances. The record keepers who maintained patient files were often illiterate or semi-literate individuals who couldn't accurately document patient information, treatment plans, or medical outcomes, and patient records were frequently lost, misfiled, or deliberately falsified to hide evidence of medical malpractice or staff misconduct. And families seeking information about deceased loved ones would be told that no records existed, making it impossible to hold hospitals accountable for wrongful deaths, or to learn from medical mistakes that could have prevented future tragedies. Let's now examine the physical structures and environmental conditions that made hospitals such deadly places, starting with the architectural design of these buildings, which were typically constructed without any understanding of disease transmission, patient comfort, or medical functionality, and most hospital buildings were converted from other purposes, such as workhouses, prisons, or religious institutions. And these structures were never intended to house sick individuals and lacked the basic features necessary for proper medical care, such as adequate ventilation, natural lighting, or sanitary facilities. The ventilation systems in 1800s hospitals were either non-existent or actively harmful, with buildings designed to trap air inside rather than promote circulation, and windows were often sealed shut to prevent patients from escaping or committing suicide, creating stagnant air conditions that allowed disease-causing bacteria and viruses to accumulate in concentrated form. And patients were forced to breathe the same contaminated air for weeks or months, virtually guaranteeing that they would contract multiple infections during their hospital stays, and the lack of fresh air also created psychological conditions that promoted despair and mental breakdown among patients who felt trapped and suffocated. The heating systems used in hospitals were primitive and dangerous, often consisting of open fires or poorly designed stoves that created smoke and carbon monoxide poisoning, and many hospital fires started from these heating systems, killing patients who were too sick or restrained to escape, and the uneven heating meant that some areas of hospitals were unbearably hot while others were freezing cold. And patients had no control over their environmental conditions and were forced to endure temperature extremes that worsened their medical conditions and reduced their chances of recovery. The water supply systems in hospitals were contaminated from multiple sources, with drinking water often drawn from the same wells or rivers that received hospital sewage, creating closed loops of contamination that guaranteed the spread of waterborne diseases, and the storage and distribution of water within hospitals involved containers and pipes that were never cleaned and became breeding grounds for bacteria. And patients who survived their original medical conditions often died from cholera, typhoid, or dysentery contracted from contaminated hospital water supplies. The sewage and waste disposal systems were primitive or completely absent, with human waste often collected in containers that overflowed regularly, creating unsanitary conditions throughout hospital buildings, and waste removal was sporadic and inefficient, and hospital grounds often resembled open sewers, with human and medical waste scattered in areas where patients were supposed to walk and take fresh air for therapeutic purposes. And the smell of human waste permeated hospital buildings, creating nauseating conditions that made eating difficult and added to the psychological trauma of hospital admission. The lighting in hospitals was inadequate for medical purposes, with most patient areas illuminated by candles or oil lamps that provided minimal illumination and created fire hazards, and medical examinations and surgical procedures were performed in near darkness, making accurate diagnosis impossible and increasing the likelihood of surgical errors. And the dim lighting also created psychological conditions that promoted depression and hopelessness among patients who spent months in perpetual twilight conditions without access to natural sunlight. The construction materials used in hospital buildings were often cheap and porous, absorbing blood, pus, and other bodily fluids that created permanent sources of contamination, and wooden floors and walls would soak up infectious materials that could never be completely cleaned, and these buildings became saturated with disease over time, making them increasingly dangerous for each new generation of patients. And the porous materials also absorbed odors from infection and death, creating atmospheric conditions that were psychologically traumatic for patients and staff alike. The room layouts in hospitals were designed for institutional efficiency rather than patient comfort or medical functionality, with long corridors lined with beds that were placed so close together that patients could touch their neighbors, and privacy was non-existent, with patients forced to endure intimate medical procedures in full view of dozens of other patients. And this lack of privacy added psychological trauma to physical illness and made recovery more difficult because patients couldn't rest or heal in peaceful conditions. The storage areas for medical supplies and equipment were often located in basements or other areas prone to flooding and contamination, and surgical instruments would be stored in damp conditions that promoted rust and bacterial growth, and medications would be kept in areas where temperature and humidity fluctuations destroyed their effectiveness and sometimes created toxic chemical reactions. And clean linens would be stored next to dirty laundry and medical waste, ensuring cross-contamination that spread disease throughout the hospital system. The morgue facilities were typically located within or immediately adjacent to patient care areas, and the smell and psychological impact of constant death created traumatic conditions for surviving patients, and morgue procedures were so unsanitary that they created additional sources of contamination that spread throughout hospital buildings. And bodies were often stored for extended periods in conditions that promoted decomposition and disease, and the transportation of corpses through patient areas was a daily reminder of the likely outcome of hospital admission. The kitchen and food preparation areas were among the most contaminated spaces in hospital buildings, with cooking facilities located near latrines and waste storage areas, and food would be prepared using contaminated water and stored in conditions that promoted bacterial growth, and the same surfaces used for food preparation would also be used for cleaning medical instruments and preparing medications. creating cross-contamination that poisoned patients through multiple pathways, and meals were often prepared days in advance and stored without refrigeration, guaranteeing food poisoning for patients whose immune systems were already compromised by illness and medical treatment. The laundry facilities were sources of contamination rather than cleanliness, with washing procedures that mixed clean and dirty items together and used contaminated water and soap, and wet laundry would be hung in patient areas to dry, creating humid conditions that promoted bacterial and fungal growth, and the same equipment used to wash patient linens would also be used to clean surgical instruments and prepare food, spreading contamination throughout all aspects of hospital operations. The administrative offices were typically located in the cleanest and best ventilated areas of hospital buildings, while patient care areas were relegated to basements, attics, and other spaces that were unsuitable for human habitation, and this physical separation between administrators and patients meant that decision-makers never experienced the horrific conditions they created through their policies and budget decisions. And hospital boards would make financial choices that prioritized cost savings over patient welfare, creating systemic conditions that guaranteed high mortality rates. The chapel areas in hospitals were often the only spaces that received regular cleaning and maintenance, because religious services were attended by wealthy donors and community leaders who would otherwise never see the interior of hospital buildings, and this selective maintenance meant that resources were diverted from patient care areas to maintain appearances in spaces that had no direct medical function. And patients were often forced to attend religious services in these cleaned areas, while their own living spaces remained filthy and contaminated. The visiting areas where families could meet with patients were designed to limit contact and hide the worst aspects of hospital conditions, and families would be restricted to brief visits in controlled environments that didn't reveal the true extent of neglect and abuse occurring in patient care areas. And this deception meant that the broader community remained unaware of hospital conditions and continued to support institutions that were systematically killing the people they claimed to serve. The staff quarters within hospitals were often in better condition than patient areas, but they were still contaminated by the overall institutional environment, and hospital employees would carry disease home to their own families, creating community outbreaks that spread beyond hospital walls, and this pattern meant that hospitals became sources of epidemic disease that threatened entire communities, not just the patients who sought treatment within their walls. Let me now paint a picture of what a typical day looked like for a patient in an 1800s hospital, beginning with the early morning hours when patients would be awakened not by gentle nursing care but by the sounds of corpses being removed from the wards, because death was so common that body removal became a daily routine that patients learned to expect and dread, and the sight of their deceased fellow patients being dragged away served as a constant reminder of their own likely fate. The morning routine would begin with a cursory inspection by whatever nurse happened to be assigned to the ward that day, and this nurse would have no knowledge of individual patients' conditions, medications, or treatment plans, because record keeping was so poor and staff turnover so high that continuity of care was impossible. And patients would have to repeatedly explain their symptoms and medical history to staff members who showed little interest in listening or learning about their specific needs. Breakfast, when it was provided at all, consisted of thin gruel or stale bread that was often moldy or contaminated with insects and rat droppings, and the same meal would be served to all patients regardless of their dietary needs, medical conditions, or ability to digest solid food, and patients recovering from surgery would receive the same food as those suffering from severe digestive ailments. And many patients would become sicker from eating contaminated hospital food than they had been from their original medical conditions. The morning medical rounds conducted by physicians were rushed affairs where doctors would spend only minutes with each patient, making treatment decisions based on superficial observations and ancient medical theories rather than careful examination or scientific understanding, and patients who attempted to describe their symptoms or ask questions were often dismissed or ignored, because physicians viewed themselves as authorities who didn't need input from ignorant patients, and this arrogance meant that serious complications and changing conditions were regularly missed until they became life-threatening emergencies. Medication distribution was haphazard and dangerous, with the same nurse responsible for dozens of patients and no systematic method for ensuring that the right medications reached the right individuals, and drug errors were common, with patients receiving medications intended for others or missing doses of critical treatments, and there was no understanding of drug interactions or appropriate dosages. So patients would often be poisoned by their treatments or receive inadequate doses that provided no therapeutic benefit while still causing side effects. The midday period brought the horror of surgical procedures performed without anesthesia in full view and hearing of other patients, and the screaming from surgical areas would traumatize patients throughout the hospital, creating psychological conditions that interfered with healing and recovery. and the sight of surgical patients being carried back to the wards, often missing limbs or showing signs of severe trauma, served as another reminder of the brutal nature of hospital treatment and the likelihood that any patient might be subjected to similar procedures. Afternoon visiting hours were strictly limited and carefully controlled to prevent families from witnessing the worst aspects of hospital care, and visitors would be escorted through cleaned corridors to designated areas while the actual patient wards remained hidden from public view, and this deception meant that families remained unaware of the true conditions their loved ones were enduring. And patients who complained to visitors about their treatment were often punished afterward by hospital staff who viewed such complaints as betrayals of institutional loyalty. The evening meal was typically worse than breakfast, consisting of whatever spoiled food the hospital had acquired cheaply, and patients with specific dietary needs would receive the same contaminated gruel as everyone else, and many patients stopped eating altogether rather than consume food that made them sicker, leading to malnutrition that further weakened their immune systems and reduced their chances of survival. And the sight and smell of spoiled food added to the overall atmosphere of neglect and degradation that characterized hospital environments. Nighttime brought its own horrors, with minimal staffing and no effective supervision of patient care, and the sounds of suffering would continue throughout the night as patients experienced pain, fever, and medical emergencies without adequate response from hospital staff, and many patients died during night hours when no physicians were present and nurses were either absent or asleep. And the morning would bring the discovery of new corpses that had to be removed before the next day's routine could begin. The bathroom facilities available to patients were primitive and shared among dozens of individuals, creating ideal conditions for the spread of infectious diseases, and patients who were too weak to reach these facilities would be forced to soil themselves and remain in contaminated bedding for days or weeks, developing bed sores and skin infections that added to their medical problems. And the smell and unsanitary conditions in patient areas became so overwhelming that even hospital staff would avoid certain wards whenever possible. Personal hygiene was impossible for hospital patients, who had no access to clean water, soap, or washing facilities, and patients would go for months without bathing, developing skin conditions and infections that were entirely preventable with basic cleanliness, and the accumulation of dirt, sweat, and bodily fluids created breeding grounds for parasites and bacteria that thrived in the warm, moist conditions of unwashed human bodies confined to contaminated bedding. The psychological atmosphere of hospitals was characterized by despair, hopelessness, and constant reminders of death and suffering, and patients would be surrounded by others who were dying, screaming in pain, or showing visible signs of advanced disease, and this environment destroyed patients' mental health and will to live, making recovery unlikely even for those whose physical conditions might have been treatable under different circumstances. The lack of meaningful activity or stimulation meant that patients spent their days in a state of passive suffering, with no books, games, or other diversions to occupy their minds and help them cope with their medical conditions, and this mental stagnation contributed to depression and despair that interfered with physical healing and made patients more susceptible to opportunistic infections and complications. The constant noise of an overcrowded hospital, with patients moaning, coughing, and crying throughout the day and night, made rest and sleep impossible, and the lack of adequate sleep interfered with patients' immune systems and healing processes, creating conditions where even minor medical problems could become life-threatening complications. And the exhaustion and stress of sleeplessness added another layer of suffering to the already unbearable conditions of hospital life. The temperature extremes in hospital buildings meant that patients would alternate between shivering with cold and sweating from excessive heat, and their body's energy would be consumed by efforts to maintain basic physiological functions rather than fighting disease and healing from injuries. And the environmental stress of temperature fluctuations weakened patients' resistance to infection and made recovery from surgery or illness much more difficult than it would have been under comfortable conditions. Now let's examine the broader social and economic factors that created and perpetuated these horrific hospital conditions, beginning with the class-based medical system that relegated the poor to institutions designed more for social containment than medical treatment, while wealthy individuals received care in their own homes from private physicians who had access to the best available treatments and medical knowledge of the era. The stigma associated with hospital admission meant that seeking hospital care was viewed as evidence of moral failure, personal weakness, or social unworthiness, and this stigma prevented many people from seeking treatment until their conditions had progressed to terminal stages, and it also meant that hospital patients were treated as social outcasts who deserved whatever suffering they experienced. rather than as human beings entitled to compassionate care and effective treatment. The economic incentives that drove hospital operations were fundamentally misaligned with patient welfare, because hospitals were funded through charitable donations and government subsidies that were based on the number of patients admitted rather than the number successfully treated, and this meant that hospitals could maximize their revenue by admitting as many patients as possible while providing minimal care, essentially operating as profitable death mills that generated income through volume rather than quality of treatment. The lack of government regulation or oversight meant that hospitals could operate with complete impunity, and there were no standards for medical care, sanitation, staff training, or patient rights, and hospital administrators could implement any policies they chose without fear of legal consequences or public accountability. And this absence of oversight allowed abusive and deadly practices to continue for decades without challenge or improvement. The charitable organizations that funded hospitals were typically run by wealthy philanthropists who viewed hospital work as a form of religious duty that would enhance their social standing and spiritual salvation. But these donors rarely visited hospital facilities or investigated how their money was being used, and they were satisfied with maintaining institutions that appeared to serve the poor without caring whether those institutions actually provided effective medical treatment. The religious justifications for poor medical care included the belief that suffering was spiritually beneficial and that the poor deserved their fate as punishment for sin or moral failings, and these attitudes meant that improving hospital conditions was viewed as interference with divine will, and hospital staff were encouraged to focus on preparing patients for death rather than fighting to preserve their lives. And this religious fatalism became a self-fulfilling prophecy that ensured high mortality rates. The political factors that perpetuated bad hospital conditions included the fact that hospital patients had no political power or social influence, and they couldn't vote, organize, or advocate for better treatment, and politicians had no incentive to investigate hospital conditions or allocate resources for improvements. Because hospital patients represented a population that was politically invisible and socially expendable, and this lack of political representation meant that hospital reform would have to come from external sources rather than from the patients themselves. The medical education system that produced hospital physicians was controlled by established authorities who had vested interests in maintaining existing practices and theories, and medical schools discouraged innovation, experimentation, or criticism of traditional approaches, and students who questioned established methods were expelled or marginalized, ensuring that new generations of physicians would perpetuate the same harmful practices that had killed patients for centuries. And this resistance to change meant that medical progress was impossibly slow and often actively suppressed by medical authorities. The professional medical organizations that could have improved hospital standards were more concerned with protecting physician social status and economic interests than with patient welfare, and these organizations would defend harmful practices and attack critics who pointed out the failures of contemporary medicine, and they would suppress research that challenged established theories or demonstrated the ineffectiveness of standard treatments, ensuring that dangerous medical practices continued long after evidence of their harm had become overwhelming. The legal system provided no protection for hospital patients, who had no recourse when they were injured or killed by medical malpractice, and families couldn't sue hospitals or physicians for wrongful death or inadequate care, because the law assumed that medical authorities knew best and that patients had consented to whatever treatment they received by seeking hospital admission. And this legal immunity meant that hospitals and physicians could harm patients without fear of consequences, creating incentives for careless and abusive treatment. The economic depression and social instability of the 1800s meant that resources for hospital improvement were scarce, and communities struggling with poverty, unemployment, and social upheaval had little money or energy to devote to improving medical facilities, and hospitals were viewed as necessary evils that served to contain social problems rather than as opportunities for community investment and improvement. And this attitude meant that hospitals received minimal funding and operated with resources that were inadequate for providing even basic medical care. The transportation limitations of the era meant that patients often arrived at hospitals in advanced stages of illness after days or weeks of travel in primitive conditions, and by the time patients reached hospital facilities, their conditions had often deteriorated beyond any possibility of successful treatment, and this meant that hospitals developed reputations for treating only the most hopeless cases, which reinforced their image as places where people went to die rather than recover. and this reputation made it even less likely that patients would seek hospital treatment before their conditions became terminal. The communication limitations of the era meant that medical knowledge advanced slowly and unevenly, with discoveries and improvements in one location taking years or decades to spread to other areas, and hospitals in different regions might use completely different treatment approaches for the same conditions, with no mechanism for comparing results or identifying which methods were most effective. And this fragmentation of medical knowledge meant that even when better treatments were discovered, they might not reach the patients who needed them for many years. The social attitudes toward pain and suffering included the belief that enduring pain was character-building and spiritually beneficial, and this meant that pain relief was viewed as morally corrupting and medically unnecessary, and patients were expected to bear their suffering with stoic acceptance. And medical staff who showed compassion or provided comfort were viewed as unprofessional and potentially harmful to patients' spiritual development, and these attitudes ensured that patient comfort was never a priority in hospital design or operation. The gender dynamics of 1800 society meant that most hospital patients were women, children, and elderly men who had no social power or legal rights, and these patients were completely dependent on male physicians and administrators who viewed them as inferior beings whose suffering was of little consequence. And the paternalistic attitudes of medical authorities meant that patients had no voice in their own treatment and no ability to refuse procedures or demand better care. And this power imbalance ensured that patient welfare would always be secondary to the convenience and preferences of medical staff. As we near the end of our journey through this medical nightmare, it's important to understand how these horrific conditions finally began to change, though the transformation was slow and met with fierce resistance from established medical authorities who had built their careers on the very practices that were killing thousands of patients every year, and the pioneers who fought for hospital reform faced professional ostracism, personal attacks, and institutional sabotage as they attempted to introduce basic concepts like hand washing, surgical sterilization, and patient comfort into medical practice. The work of reformers like Florence Nightingale, who documented the shocking mortality rates in military hospitals and demonstrated that simple sanitation measures could dramatically reduce death rates, began to challenge the established medical orthodoxy, but her findings were initially dismissed by physicians who viewed her as an interfering woman who couldn't understand the complexities of medical science. And it took decades of persistent advocacy and undeniable statistical evidence before her recommendations were grudgingly accepted by medical authorities. The development of germ theory by scientists like Louis Pasteur and Joseph Lister provided scientific explanations for the disease transmission that had made hospitals so deadly, but this revolutionary understanding was met with mockery and rejection by established physicians who refused to believe that invisible microorganisms could cause disease. And many doctors continued to operate with dirty hands and instruments even after the connection between contamination and infection had been scientifically proven, because changing their practices would have required admitting that they had been killing patients through ignorance and negligence. The introduction of anesthesia revolutionized surgical practice by allowing procedures to be performed more carefully and thoroughly, but even this obvious improvement was initially opposed by physicians who argued that pain was necessary for healing and that unconscious patients couldn't cooperate with surgical procedures, and religious authorities opposed anesthesia on the grounds that it interfered with divine punishment for sin. And these objections delayed the adoption of anesthesia for years, during which countless patients continued to suffer and die from shock and trauma during surgical procedures. The gradual improvement in nursing education and professionalization began to address some of the worst abuses in patient care, but this progress was slow and uneven, and many hospitals continued to employ untrained and abusive staff well into the late 1800s. And the resistance to professional nursing came from physicians who viewed educated nurses as threats to their authority and from hospital administrators who didn't want to pay higher wages for qualified staff, and this resistance meant that patient care remained poor in many institutions long after better alternatives had been demonstrated. The development of antiseptic surgery and sterile technique dramatically reduced surgical mortality rates, but the adoption of these practices was delayed by physicians' pride and reluctance to change established routines, and many surgeons continued to operate in contaminated conditions because they viewed cleanliness as unnecessary and time-consuming. And patients continued to die from preventable infections while life-saving techniques were available but unused, and this stubborn resistance to improvement cost thousands of lives that could have been saved with simple changes in medical practice. The construction of new hospital buildings designed specifically for medical care began to address some of the environmental factors that had made hospitals so deadly, but these improvements were expensive and slow to implement, and many patients continued to receive care in converted buildings that were unsuitable for medical purposes, and the new hospitals were often built only in wealthy areas. leaving poor communities to continue using the same deadly facilities that had been killing patients for decades. The development of medical record keeping and statistical analysis began to provide objective evidence of treatment outcomes, making it harder for hospitals to hide their mortality rates and forcing some improvements in care. But many institutions resisted accurate record keeping because they didn't want to document the extent of their failures. And families of deceased patients still had difficulty obtaining information about what had happened to their loved ones, and this lack of transparency allowed poor practices to continue in many hospitals well into the late 1800s and beyond. The gradual recognition of patients' rights and dignity began to challenge the authoritarian medical culture that had treated patients as objects rather than human beings. But this change was slow and incomplete, and many patients continued to receive care that was technically competent but emotionally cold and psychologically damaging. And the paternalistic attitudes of medical authorities meant that patients still had little voice in their own treatment decisions, and this lack of patient autonomy continued to cause suffering even as technical medical care improved. As we reach the conclusion of this dark journey through medical history, I want you to take a moment to appreciate the incredible transformation that has occurred in medical care over the past century and a half, because the sterile, comfortable, technologically advanced hospitals we know today represent one of humanity's greatest achievements in reducing suffering and preserving life, and every aspect of modern medical care, from the antiseptic operating rooms to the compassionate nursing care, to the patient rights that we take for granted, represents victories won through the dedication of reformers who refuse to accept the deadly status quo of 1800s medicine. The next time you visit a modern hospital, remember that the clean sheets, the careful hand washing, the pain medications, the informed consent procedures, and the basic human dignity that characterize contemporary medical care were once revolutionary concepts that medical authorities rejected and fought against, and thousands of patients died unnecessarily because these simple improvements were delayed by professional pride, institutional inertia, and resistance to change. And this history reminds us that medical progress is not inevitable but requires constant vigilance and advocacy to ensure that patient welfare remains the primary goal of healthcare institutions. The horror stories we've explored tonight serve as powerful reminders of how quickly medical care can deteriorate when institutions prioritize convenience, cost savings, or professional authority over patient welfare, and they warn us to remain alert to signs that our own healthcare system might be developing problems similar to those that made 1800s hospitals so deadly, because the same human tendencies toward pride, greed, and indifference that created those medical nightmares still exist today and could create new forms of institutional failure if we're not careful to guard against them. I hope that this journey through medical history has given you a new appreciation for the blessings of modern healthcare and a deeper understanding of how fragile and precious these improvements really are, because they represent the accumulated wisdom and sacrifice of countless individuals who fought to transform medicine from a profession that often caused more harm than good into one that genuinely serves to heal and comfort those who suffer. And as you drift off to sleep tonight, you can rest comfortably knowing that the medical care available to you and your loved ones is safer, more effective, and more compassionate than anything our ancestors could have imagined, and that the nightmarish conditions we've explored tonight belong firmly in the past, preserved now only in history books and bedtime stories like this one as reminders of how far we've come and warnings about how far we could fall if we ever stop working to make healthcare better, safer, and more humane for everyone who needs it.